I hope to address the title in short. We will discuss today, first of all, basal estradiol. Assessment of estradiol at initiation of stimulation is frequently performed in IVF XC cycles, and an elevated level usually signifies the presence of a simple cyst, which is then confirmed at ultrasound. However, prediction of the outcome of stimulation has also been attempted using estradiol level at initiation of stimulation. The systematic review by Brockmans et al. Investigated this issue in 10 studies. The sensitivity of basal estradiol in prediction of poor response ranged from 3 to 93 to 83%. The specificity ranged from 13 to 98%, and this demonstrated that basal estradiol has a low accuracy in prediction of a poor response. Since the publication of this meta-analysis, a few more studies have been published assessing the predictive accuracy for basal estradiol in ovarian response prediction, and they have confirmed the low accuracy of basal estradiol measurement in prediction of poor response. And usually we use this criteria for pituitary down regulation: E2 less than 50, LH less than 5, B4 less than 1, endometrial thickness less than 5, and follicle less than 8 millimeters. But in a study by Calhaz, George et al. In 1995, they said that the degree of pituitary suppression had no effects on either the ovarian response to gonadotropin, including HMG requirements, or the overall IVF results. Cycles were divided in groups according to estradiol level before HMG administration, 3 groups less than 20 and between 20 and 50, and from 51 to 100. But also measurement of E2 at the beginning of antagonist cycle is not well evaluated. Regarding progesterone, in a proportion of cycles, progesterone remains elevated at menstruation. And this elevated progesterone levels at the intended starting date of controlled ovarian stimulation could be associated with reduced pregnancy rates. A recent meta-analysis combining 3 prospective cohort studies, including more than 1,000 women, reported that elevated progesterone level more than 1.5 to 1.6 nanogram per milli on cycle day 2 prior to initiation of stimulation is associated with a 15% decreased probability of ongoing pregnancy in patients treated by gonadotropins and NRH antagonist for IVF. But Fusilli et al. Showed that progesterone assessment on day 3 of stimulation is inaccurate in predicting clinical pregnancy. So assessment of progesterone level on day 2 of the cycle at the start of controlled ovarian stimulation, progesterone level more than 1.6, is probably not recommended. But another study by Motlo et al. In 2017 done and said that basal progesterone level were associated with increased incidence of pre-ovulatory progesterone rise, but not with the occurrence of clinical pregnancy rates in XC cycle with GnRH antagonists. But the cutoff value in this study was very low. It discriminates about 0.65 nanogram per milli. And basal progesterone is not practiced now for detection of pituitary down regulation. Regarding LH, optimal serum LH concentration at the beginning of ovarian stimulation after pituitary down regulation with GnRH agonist is neither less than 0.1 international unit per liter nor more than 2.5 international unit per liter. This is in some studies, which are the levels of LH required in follicular development. And this means that excessive pituitary suppression, meaning less than 0.1 serum LH level, requires exogenous LH to increase the number of mature oocytes and good quality embryos. But in a study done by Cabrera et al. In 2005, they said that LH levels during the early and late follicular phase in women less than 40 years of age with normal ovarian function, desensitized with GnRH agonist and treated with recombinant FSH are not predictive of ovarian response to pregnancy or delivery. While in another study by Prasad et al., they said that patients with an elevated FSH-LH ratio, they used FSH-LH ratio and not basal LH. And this has reduced the ovarian response to stimulation and the pregnancy rates in IVF treatment, while low basal day 3 LH concentration alone didn't have a statistically significant negative impact. And another study said that there no significant difference in the rates of implantation, clinical pregnancy, and miscarriage among groups with different basal LH level during IVF cycle, but this cycle was HMG plus medroxyprogesterone acetate protocol. Ammar et al. In 2014 said that LH estimation is not mandatory in ART cycles with GnRH antagonist protocol. While in a study by Debalo et al., they said a lower trend for LH concentration from baseline to the end of ovarian stimulation is related to higher pregnancy rate, regardless the type of GnRH antagonist protocol used. In this study, they compare fixed versus flexible protocol, this one, versus the pregnancy rate. They studied LH level, basal LH, basal estradiol, and basal progesterone. There was no difference in progesterone and LH level, but the most important one is the level of LH. Basal LH in the left side here, the occurrence of pregnancy was related to lower level of LH in the cycles. So in conclusion, we can say that basal estradiol is important to check pituitary downregulation and not for prediction of response. It's not important in antagonist protocol. Basal progesterone may be of value in prediction of pre-ovulatory progesterone rise, and it is not mandatory to check pituitary downregulation. Basal LH is important to check pituitary downregulation. It may be predictor of response in antagonist protocol. And thank you.